exciting. So again, yeah, this is cardiac emergencies. So anything that kind of presents acutely or the kind of more serious clinical conditions that affect the cardiovascular system. We'll start with just interpreting ECGs really, really briefly, because what I was thinking is, do a little bit of a trade-off here. If you guys are happy to fill in the survey at the end, I've made a little document, that you guys can have of like a detailed explanation of ECG interpretation, particularly with axis deviation, which I think is something that is less well explained. And then also looking at STEMI management from the start, including assessment, symptoms, pathophysiology. So if you're happy to fill in the survey, we could do like a little trade-off, if that's okay with you guys. I also can't see the chat function anymore. Okay, here we are. Okay, perfect. Yeah, feel free again, like I said, just to chime in the chat function if something's not clear or if I'm beating a dead horse and you already know it. So, ECG interpretation. I think that the best way to treat an ECG is just take it really systematically, treat it like a timeline, because if you think about it, that is pretty much what an ECG is. It's a timeline of depolarization and then repolarization in the cardiac myocyte. So starting from your atrial depolarization, which is your P wave, your QRS complex, which is the ventricular depolarization, and then your T wave, which is your repolarization phase. So at each point saying to yourself, rather than it just being a line on a graph, it's, okay, well, this took quite a long time to repolarize, and why might that have been, or what could have caused this repolarization to take longer? And I think if you cover each of those bits and follow it like that, starting at P, going to your PR, checking for your P and QRS association, then you can't really miss anything. And even if you do, they can tell that you've tried to take a systematic approach to it, and no one can really criticize you for that. So, like I said, starting with an ECG, do all the basic introduction, background, the kind of like spiel you get in an OSCE, so they know that you know what you're talking about. Looking and comparing it to past ECGs. Then we move on to rate and rhythm. I won't focus on that too much now because it's in the document, but essentially I look at rhythm first so I can work out how to calculate the rate, and most of the time I end up just timesing it by 6 anyway. So count the QRS complexes in a strip, which is 10 seconds, and then times it by 6 to get a full minute's worth. Axis, again, won't cover today. It can get a bit overcomplicated, I think. So I've tried to break it down and really explain why things happen. I find that if I can't explain something, then I probably don't understand it. And that's probably quite a good tactic for you guys as well. If you can explain it to somebody else, like your mum or your dad, then, unless they're like a cardiologist and they're just gonna like rip you to shreds, then I think that's helpful. Okay, and then again, so following that pattern, so it's the P wave, looking at the P wave, seeing if there are P waves, seeing if the P wave is always followed by a QRS complex, so it's sinus, looking at the PR interval, which can get affected by different conduction pathways and by electrolyte abnormalities. So things like Wolff-Parkinson-White gives a short PR, but then you get a long PR in things like heart block. Looking at the QRS segment, seeing if it's narrow, which suggests that this is ventricular depolarization here. So if you have a narrow complex, it suggests the depolarization happened before it got to there, and that's why it's shorter. Or you could have a broad QRS complex, and then that means that it's been prolonged, something's blocking it, so that's heart block. Looking at the ST segment, seeing if it's elevated, so this bit here on the isoelectric line, which is the general line, if that's raised, that's ST elevation, and if it's lower, then it's ST depression. It's kind of as complicated as it will probably get tonight. And then finally looking at the T wave, which again can change quite dramatically with electrolyte problems. So I'm sure you guys have heard of hyperkalemia and tall tented T waves. Cool. Right, I won't hound it too much then. We'll leave it at that. This is a normal ECG, so we've got, this is the rhythm strip, which we can use to kind of calculate the rhythm and the rate. Then we look at the P waves, but always followed by QRS. So that's a sinus rhythm. We've got the PR interval, which is completely fine here. the QRS complex is fine, the ST segment is not elevated or depressed, and the T wave is normal. I know it looks a bit big sometimes here, but overall, can you see the general pattern is okay, so that's fine. Yeah, is everyone clear with that? Let me know in the chat if there's anyone wants me to slow that bit down. Okay, until then. So, looking more generally now at conditions, I like to break things down into kind of the different aspects they could ask you about. So for me, I find that if I read all of the, if I learn a condition and then at the end of the condition take a step back and I can answer just like a sentence about each of these questions or each of these topics, then I've probably covered enough detail to be comfortable with whatever they throw at me. So what is it? And being able to explain that both medically but also to a patient, and saying, and to basically having it in the kind of the jargon, but also in an OSCE situation, could I explain this to somebody without looking like a knob? What causes it? Again, you don't need to like hound going over every single cause, but having a couple at the top of your head that you can just kind of whip out, that's always helpful. Symptoms, investigations, diagnosis, including differentials, treatment, monitoring, and complications. So if you can answer all of those, you've probably done enough. With that, so I like to think of it as working smart, not working hard. I find that sometimes, especially in fourth year, when there's so much content, it's so easy just to keep going and learn and spend like 8 hours a day revising, which is just not helpful. You're not going to remember that stuff come September. I'm really sorry, by the way, that sucks. So I think it's about linking it all together in your head. I'm really visual, and so for me, I like to kind of almost make a mind map in my head of what's going on. So I will always link to other conditions, and I'll say, okay, I'm looking at edema here in the heart, but what about what conditions have edema kind of like nephrotic syndrome or preeclampsia and cerebral edema, and see how I can kind of compare and contrast between them. Or, for example, we'll look at some links later today, but everything's connected. Also, I like to think about an OSCE link. So again, could this be an OSCE station? And what kind of station would it be? And then thinking about buzzwords. So if I was writing a question for an exam on this condition, what kind of things would I put in the question so that they knew this is what I was thinking? And I think if you start thinking like the examiner, it makes it so much easier to actually kind of answer the questions that they want you to answer. And then finally, before we get onto some actual medicine, e-boxes. This is my personal way of kind of approaching investigations. I find that if I have a structure, it does two things. One, in an OSCE, it looks good, you look slick, and you seem like you know what you're doing a bit more, but also you've taken away some of that kind of cognitive load of having to like dig deep in your head for the echo. Whereas if it's in this structure, you can just focus more on your explanations and your justifications rather than thinking of what comes next. For me personally, doesn't work for everyone, but just thought I'd share it. Okay, so acute coronary syndrome. I don't want to spend too long on this because I know you guys know what the symptoms of a STEMI is. I don't want to patronize you. So it's cardiac chest pain, you got shoulder tip pain and your jaw pain because of the way it refers and it radiates. And they might be short breath, they might be cold, they might be clammy, they might be stressed out, like me right now. But they generally, those are the kind of common cardiac ischemic conditions, because acute coronary syndrome is basically a series of ischemic cardiac acute events. So that's your MIs, your myocardial infarctions, and also your unstable angina. So in a question, the things that you should be thinking of are cardiac chest pain that's lasted longer than it normally does, or it's occurred at rest, or it's getting worse. That would kind of make me think this is more than just a normal angina picture. And they'll have some risk factors. So they'll have hypertension, they'll have had, you know, an MI in the past, or they have atherosclerosis. Okay, we won't spend too much time on the general assessment, but could someone in the group just say that there's two main investigations they would do if they had someone with the kind of the acute? Straight in there, wow, Smashing it, yeah. So an ECG, is there anything else you'd want to do? Yeah, perfect. ECG, troponin. Well done, guys. So those are the two most important things, because the criteria for ACS is based on ECG and troponin. But obviously you also want to rule out stuff. So going back to e-boxes, you'd want to do a full blood count, UNEs, LFTs, you want to do an X-ray, do ECG, and you could argue for some other special tests as well. Okay, so we've said about the fact that you need the ECG and the troponin. If I showed you this here, so someone's come into the A&E department and they've got signs and symptoms that are suggestive of that acute coronary syndrome. We've done an ECG and we've ordered the troponin, but the troponin might take 20 minutes to an hour in a busy department. And we have to take 2 serial troponins, because troponin is at its highest about 3 to 6 hours after the initial kind of ischemic damage starts. So we have to do something in between. The ECG is quite quick. And again, that breaks it down into 2 areas. You could have ST elevation, which is your STEMI, your ST elevated MI, or you could kind of have not ST elevation. In my head, before last year, I kind of thought that, oh, well, NSTEMI is always ST depression, T-wave inversion, and then unstable angina is just normal. But actually, the level of ischemia in unstable angina can kind of mimic the ST changes in NSTEMIs. And NSTEMIs don't always necessarily have ST changes. So it kind of leaves you in this weird position. So let's focus on the STEMI people for a moment. They've come in, they've got the ST elevation. The troponin's not back yet, but we're pretty confident from the ST elevation that they're going to have, that they've got NSTEMI. What are we thinking of doing for this person? Someone want to post in the group? Perfect. Yeah, so both of those things. So MONA basically is an acronym people use for the initial acute management of a STEMI, and I've written a bit more about it in the document I made, but essentially it comes down to this here. So that's morphine, oxygen, nitrates, aspirin. And as you said, completely right, you need to do some primary PCI as well, and that's a form of reperfusion. That's because a STEMI essentially happens when an actual kind of plaque ruptures in like a fibrous plaque, the cap of the plaque ruptures and a blood clot forms, and that blood clot actually blocks off the entire artery, so they get in like complete necrosis of the muscle wall, which is what they call it, transmural. I'm sure you've seen that before. So you need to get them dealt with quite quickly, because no amount of drug is going to kind of break that down. Well, or is it? We'll see. So we want to try and get them in, and that's why your history is so important here. So you need to know how quickly those symptoms started and how long ago. Kind of research suggests that within 12 hours, PCI is kind of effective, but after 90 minutes, it's no more effective than thrombolysis. So if you're in, say if you're in the Royal at Aintree, you're not in heart and chest yet, which is where PCI happens in Liverpool, and you don't think you can get them there and having PCI within 90 minutes of symptom start, of onset, then being honest, you're probably better keeping them where they are, where they're stable, and not making them go through that transfer and just sticking to the thrombolysis. But generally we could do the stenting, which is the primary PCI. So essentially you use a stent and you inflate it and you try and keep that airway patent. And the idea is that it just keeps the flow going through, and they can try and reperfuse that way. But if we go back to our patients who are unstable and have unstable angina or an NSTEMI, they're kind of complicated, because again, until that troponin comes back, we don't know if they're unstable angina, which is ischemia, or if they've actually experienced necrosis, which is the NSTEMI. So we kind of get stuck in this position of what we're going to do in the meantime, and we can use something called the GRACE score to try and work out what to do. Have you guys heard of the GRACE score before? So that's okay. So the GRACE score is a mortality risk assessment tool. What you do is you essentially put in all the kind of patient details. So there's some of them here, like age, heart rate, systolic blood pressure, and you take all that information and it helps you kind of work out a score, and that will help decide your next step of the management plan. So whether you go for a stent or you go for thrombolysis, or whether you just kind of stick to the management that you're doing at the moment. And they typically say a score over 140, which is, if I show you here, score over 140 indicates that you need to do early invasive strategy with the NSTEMI or unstable angina patient. And this can be quite helpful because, again, you can be quite unsure about what to do with these patients, and you run the risk of not doing enough. And if they have got necrosis, they're just as unwell as those STEMI patients. So you need to kind of get in there quick. Does that make sense? Is everyone okay with that? The last thing I guess to say is just that if a stent doesn't work, you then go on to a CABG, which is an actual bypass graft. So you use a piece of vein and you graft it on, and it can be a single, double, triple, or quadruple bypass. So the more kind of new coronary arteries you form, the higher the number. Cool. Thanks, guys. I appreciate all the interaction. This is just a list of complications. I won't go through it because I think you just need to read it in your own time. And I think that this diagram explains it quite well. But if you have any questions, just let me know. Okay, so moving on, we're talking now about AF. So AF is almost always fast. That's not something but not always. I didn't realize that you can have slow AF. And when you talk about the kind of fast AF that clinicians talk about, and I never had any clue what they meant during ward round. This is what they mean. They mean an atrial fibrillation picture with a rapid ventricular response. So first of all, what is AF? Does anyone want to tell me, just like 2 lines, how would you define AF? Yeah, I like it. Oh, thanks, Shannon, for the kisses. Yep, very true. So this is it's uncoordinated atrial activity. You have an irregular rhythm without a P wave. And yeah, it's a supraventricular arrhythmia. This is sick, well done, guys. So I won't kind of bore you with the symptoms, because it sounds like you guys know what kind of symptoms you'd expect with that. Your shortness of breath, dizziness, palpitations, tachycardia. They might present with syncope, and it might be that they've never even realised they had AF. In fact, quite a lot of the time, AF kind of just ticks along in the background, and it's picked up incidentally, or it's picked up secondary to a condition like an infection, or they present with kind of a decompensated picture, and then the cause is found to be AF. So, with that in mind, I have a list of kind of some conditions that can cause AF. And I don't know why, but for some reason this never stuck with me. I could just never remember it. Apart from infection, that was the only thing that stuck with me. I guess because most people don't have atrial myxomas. I have seen one person in my entire life. I say life, I'm 22. But and that was not even a patient who had a myxoma. So it's really rare. What we're going to focus on today is hemodynamic instability, which is quite rare, but I think is really serious and not something that's taught that well compared to kind of general AF management, which I think is not that badly done, and for good reason, because I think it's definitely fair game to come up in exams, whether that's an OSCE, as an ATE assessment, or explaining AF to a patient, or kind of explaining anticoagulation. That could definitely be something that would come up, and also something that's generally less well done, because I know how tempting it is. I'm very guilty myself of not really going over that stuff and focusing more on respiratory management. So hemodynamic instability and AF. This is essentially where your blood pressure is dropped and they become shocked. And this is usually in response to their heart rate rising. So usually what happens is a patient has kind of already quite poor left ventricular function. And because of that, they're already quite dependent on their atrial contraction. So during a normal cardiac cycle, about 15% of ventricular filling is secondary to atrial contraction. But if you have AF, that contraction is really discoordinated. It's not very effective. So they're getting less blood from that, and that really makes a big knock in their left ventricular functioning. On top of that, you have less diastole because it's a tachycardia. So that means that you're also having less blood filling, you have less venous return, you get less blood going to your coronary arteries, and you get ischemia, which just worsens their function. So it's kind of a vicious circle, if that makes sense. And again, this only happens when your heart rate is really fast, like 150 and above. So it's quite rare because most people don't get to the point of having a heart rate of 150. They present a lot sooner, and then medications are given to terminate this episode. Is everyone okay with that so far? Okay, so talking about how do we manage this person then. They've got the palpitations, they've got the shortness of breath, they have the irregular ECG. And in this situation here, they're not very stable. So they've got a low blood pressure, and maybe they have reduced consciousness. They're just generally not quite right. The first thing we want to do is cardiovert them. So that's synchronized cardioversion. And we'll talk a little bit about what that means later on. So don't worry if that's not something you're familiar with. But essentially using an electrical current to try and resynchronize the heart rhythm. You also want to put them on some anticoagulants because it's quite a thrombotic state to be in. The blood is basically stationary in the ventricle. You have venous stasis, and that's a really prothrombotic event. So they just clot and then they get a stroke. It's really quite terrifying, particularly if you aren't someone who was aware that you even had AF to begin with. So we want to cardiovert them, anticoagulate them, do the full A2E assessment. And if that fails, try it again, and then try medical cardioversion. We'll also touch quickly on what to do for people who have stable AF in the emergency department. So I wasn't aware of this, but actually people who have stable AF can be given rhythm control, and you can try and cardiovert them within 48 hours. If it's the first 48 hours of the symptom developing, you can try and cardiovert them. And again, that tends to be rhythm control. So you can give them some low molecular weight heparin to anticoagulate them, and then either do a pharmacological or electrical cardioversion. And if they're stable, it doesn't matter which one. Pharmacological wise, you can do amiodarone if they have heart disease, or flecainide if they don't. Just keep it as simple as that. I don't think it needs to get more complicated. If it's been more than 48 hours, it gets a bit more difficult. So kind of best practice suggests that you still anticoagulate that patient, counsel them, explain what's going on, and then you're going to rate control them. And again, we're not going to focus too much today on rate control versus rhythm control, but in essence, rate control is better for older people, and it's better for people who are less stable. Rhythm control tends to be better for younger people because there's less chance of remodeling. If you think about AF and the nature of it, the heart has to remodel to kind of cope with that. And if you're a younger person, that's more time that your heart needs to remodel for, and the implications on your general well-being will be more significant. So in this scenario though, if it's been more than 48 hours, sadly you have to rate control. And you're aiming for a heart rate of about 110 or below, so you don't want them to be too tachycardic. You also want to anticoagulate them, and then you're going to refer them to cardiology, if appropriate, with the view to try and rhythm control them using interval cardioversion, where you try and cardiovert them for short periods of time until it hopefully just goes back to normal again. Okay, take a second. I know that's a lot of information. Does anyone have any questions at this point before we carry on? So 2 questions. I think Shannon's still writing one. Or what does DC cardioversion mean? And also, if it's an incidental finding, do you assume it's been more than 48 hours, and rate control? So those are really great questions. So we'll start with Shannon's one, and then I promise to talk about the DC cardioversion as well. So if it's incidental, then you can take a history from them and ask, how long has this been going on for? Have you ever had any palpitations? Have you ever had any dizziness, any syncope? And most likely they'll know if they've had syncope, they'll know if they've had dizziness, but it probably will just be an incidental thing that they haven't even realized. In which case you would have to rate control, speak to a cardiologist, and discuss whether they would be appropriate for an attempt at rhythm control after 3 weeks. And I should have just said before as well, the reason you have to wait the 3 weeks to rhythm control them is because if you tried after 48 hours to just straight up kind of shock them, you have a really strong risk of dislodging any clots that have already formed, and they might end up having a thrombotic event, and it'll be your fault. So, but then also you need to remember that sometimes AF can happen secondary to infections. So it could be that they've come in, they've had an infection for a couple of days, and like 2 days, and then now they've developed this AF. Less likely, but could happen. Okay, and DC cardioversion, really great question. I had no idea until about 6 months ago, after finals. So basically, cardioversion is a type of, DC cardioversion is a type of electrical cardioversion, so you're shocking them to try and resynchronize it. The DC is a direct current, and that's part of the fact of it being synchronized. So before, when I said you're going to synchronize it, you are going to time it with your pulse and with systole, and you're going to shock them at systole. And that's because if you miss aim and you accidentally shock them out of systole, you run the risk of sending them into VF. And that's probably the biggest difference between defibrillation and cardioversion. So defibrillation is a form of cardioversion, but you're not worrying about the synchronicity or when you shock them, you just shock them at any point. And that's usually because you can't find a pulse, the electrical activity is too fast, or, well, those are the main two reasons really. Does that make sense? No worries. Okay, so carrying on, we're doing really well here. Just a little bit about CHA2DS2-VASc and has-bled. I'm not going to go over it because I think you just need to sit and learn it, boring as it is, but I would recommend learning it. The way that they tend to ask these questions in a written paper is, rather than saying, what are the things of CHA2DS2-VASc or has-bled, they say, what factors in a patient's history would make you more concerned about their bleeding risk? And that would be their way of saying, do you know the aspects of has-bled? So we had a similar question. We got asked about what features would make you more worried about a venous thromboembolus. And the idea was that you had to kind of discuss the Wells criteria without actually ever necessarily saying Wells criteria. So that's just a little tip, that just think about what they're asking and what they might be wanting from you with each question. But yeah, we won't go through it today. Honestly, it's just something to go over in your own time. Just take it slowly. You've got loads of time. So cool. I won't go over bradycardia because I think it's all you really need to gain from this is bradycardia, heart rate less than 60, atropine. It's not, you use atropine to try and bring it up, and that works really well for most forms of bradycardia, except for like some drug-induced types. And it's 0.5 milligrams. I don't think this would come up as a station in its own right, but I guess if it was an A to E assessment, they very easily could have bradycardia, whether that's a Cushing response, whether that's hypothermia, whether that's, they're probably the main ones, to be honest, that, or cardiogenic shock, I guess. So those are the ways that this would come up rather than it just being a random question about bradycardia. But I'll leave the slides there for you. Cool. And again, this is a little bit about nodal blocks. So that's another form of bradycardia. This is first degree heart block, second degree and third degree heart block. We won't necessarily go over it today, but I've got some, I can put some stuff in the document about it if you want some clarification. And I've included these little comic books that I love. I think they're so fun. And I just think they kind of sum up everything nice and simply and in a way that you can remember. So yeah, I particularly like this one. Okay, so moving on now. I think this is stuff that's a bit more, maybe less well taught by the med school. How is everybody doing? Does anyone have any questions? Or is everyone all right? Okay. I'll take that as everyone's okay. So, talking about to shock or not to shock. So these are the times when someone's unresponsive and you then are left with the decision of whether they will benefit from a defibrillatory shock or not. So does anyone know the two kind of shockable rhythms and the two non-shockable rhythms? Straight in there, Shannon, wow. And Chris, there we go, look at this. Perfect. Yeah, so VF and VT. So can we have a bit more detail? What kind of VT is it? There we go. Yeah, so pulseless VT and all forms of VF, which are kind of pulseless by nature, but still very true. Pulseless VF and VT are shockable rhythms. And again, remember this is defibrillation, so we're not worrying about trying to synchronize it to the pulse because there is none. What are the non-shockable rhythms? Oh, there we go. They were typing it in advance. I knew it. So yeah, PE and asystole. And we have a little picture here to show. So we have your asystole, which is a complete flat line, no electrical activity. You've got your pulseless electrical activity, which is kind of rhythmic, slow, wide QRS complexes that are no pulse centrally. And then we've got our pulseless ventricular tachycardia, which is our regular, rapid, broad QRS complex kind of tachycardia, and there's no pulse. And we've got our ventricular fibrillation, which is this unsynchronized, chaotic, arrhythmic kind of contractions. Essentially, your ventricles are just like shaking and fibrillating. And in the middle, I put this. So this is a form of polymorphic VT. So it's a VT that can take more than one shape. And the reason I've put it in between VF and pulseless VT is because it is a form of ventricular tachycardia, but if left untreated, it can descend into ventricular fibrillation. And that's just, I don't know how to pronounce this. It's one of those things I hope I never have to say out loud. Torsade de Bois? French. Go on, Jack, you're French, you can tell us. How do we pronounce it? Oh wait, no, they can't hear you. Doesn't matter. So that's another thing to consider as well. And in general, you would try and treat that with magnesium, IV magnesium, but if they become unstable and unresponsive, then you just need to treat it like normal VT, pulseless VT, and shock them. So going back, this is the kind of algorithm for it. So a patient's unresponsive, you do the whole look, listen, feel, head, tilt, chin lift, call 222, attach your CPR or defibrillator, get them to assess the rhythm, and then quite quickly it will tell you if it's non-shockable or if it's shockable. We'll start with non-shockable rhythms. So this is where you can't really do anything but CPR. You can whack them with a bit of adrenaline, try and get their heart starting again, try and get it pumping. Otherwise, you're going to have to be their pump, which is why you do CPR. And you give them that adrenaline every 3 to 5 minutes and just keep checking their rhythm. So unfortunately, unless you can find a reversible cause and treat it, the prognosis is usually quite bad. What about shockable rhythms? So a bit more to do here, a bit easier. So you can give them, so you've checked it, you found that they have a shockable rhythm, give them that shock. And it's really important, remember, so hands off. If they're on oxygen, stop the oxygen for a second, if need be, because you don't want to explode everybody. And give them the shock, and then go straight back to CPR immediately. They say less than 5 seconds off the chest for good quality CPR. So you're doing that CPR again for 2 minutes, then reassess the rhythm. If nothing's changed, you're going to shock them again. And this time you're going to shock them with a higher voltage. If alongside that, you also want to give them that adrenaline. So you're going to give it every 3 to 5 minutes, same as in a non-shockable rhythm. And you also want to give them amiodarone after the 3rd shock. And that's usually the level of detail they want from you. So everything up to that 3rd shock, amiodarone, and knowing that every 3 to 5 minutes you give adrenaline. You could even draw a little timeline for yourself if you're a visual person. If not, you don't have to. Okay, and obviously alongside that, they need continuous monitoring. So they need an ECG, they need the pulse oximetry, they need waveform capnography. So if you don't know what that means, essentially you put a little, when you intubate them, you use a little tube and it checks their carbon dioxide levels, and it presents it as a wave, so you can see the levels and you can see how they're breathing essentially. And yeah, frequent rhythm checks. So how is that? I know that's a lot of information. Is that okay? Feel free to just ask me a question about it. But if not, we'll move on to aortic dissection. And we're doing well. We're more than halfway for sure. So aortic dissection, again, it's something I think is done less well in terms of teaching. So a typical case history. But no, that's even before that. Does someone want to tell me what aortic dissection is, or what they know about it? Go on, show off. Let us all know. Yeah, perfect. That's really well said. So basically, the innermost layer of the vessel, arterial vessel, is torn, and they present with this kind of really classic vascular hyperacute pain. So all vascular pain is usually really fast, which is the hyperacute bit. It's not just a couple of days, and it's sudden and it's excruciating. There are people who come into the department screaming, and it's a really kind of tearing pain. It's not necessarily in your chest, so they tend to say if it's in the ascending aorta and the aortic arch, it's a chest pain, and if it's in the descending aorta, it could be back pain as well. So don't get caught out by that. Alongside that, they'll have, what other kind of symptoms might you expect in aortic dissection? Definitely loss of consciousness, vomiting. Any positional changes? Yeah, very good. Is there anything kind of very specific to aortic dissection? If you look at the case history, you might see it in there as well. Yeah, radiating to back, blood pressure differences, perfect. So their blood pressure is, one, it's very high. So, I mean, in the right arm, it was 195 over 90, which is really, really quite high. And that says two things. One, the fact that hypertension is a really significant risk factor for aortic dissection. And that's because high blood pressure is a shearing force. So if your blood is constantly moving at high pressure through the vessel, it starts to shear at the actual wall itself. So that's part of it. But also your body is trying really desperately hard to keep up your cardiac output by keeping your blood pressure high. So that is kind of a catch-22 of they're trying to keep the cardiac output going, but also they are making it slightly worse. And then, like you said, Eve, you get that unequal BP in your arms, and it's quite a big discrepancy, like 20 to 30 millimeters of mercury. You might have weak peripheral pulses, particularly if it's descending, or they might be absent completely as well. So in terms of the buzzwords then, like we've said, chest pain, that sudden onset, or back pain, might radiate to your arm, cool peripheries, weak femoral pulses, hypertension, past medical history. And it tends to be like middle-aged men, like late middle-aged men, which is why they get screening for it, because they're at high risk of abdominal aortic aneurysms. And I don't think this would come up as a station, it would be a very strange station, but they might ask you to give it as a differential. Would you need to know the classifications? Yes, so you need to go to classifications, which we're just going to come on to now. You need to know the classifications, but the level of detail, I think, is more of a kind of query. Don't know how much you would need to know. I think for the thing that I was comfortable learning, the level of detail I thought was enough for me was knowing Stanford is the most common classification used for aortic dissection, and it's A and B. And with that, you can say, so Stanford A is all the A's. It's ascending aorta and the aortic arch. And this is the most common type. And then we have Stanford B, and that begins below the brachiocephalic. So the descending aorta kind of below the brachiocephalic. So the subclavian artery, basically. And that's less common. So in terms of symptoms wise as well, that kind of plays into it. So if you think about it, if you're dissections occurring at the aortic root, you might, and you think about the anatomy of the heart and the fact that the first branch off the aorta is the coronary artery. If you have a dissection at that point, you might get some ischemia and some ST elevation because you're reducing your blood supply to the coronary arteries. Whereas if it's dissecting towards the pericardium, you might get some cardiac tamponade symptoms. And if it's dissecting lower down, you might get some weak pulses peripherally, and you might get some cool leg, I think is what we had in our exam this year. Was they had like this guy fainted suddenly and then he had really cool legs and you had to work out why. So yeah, A and B for those. Does that make sense? So A is ascending aorta and aortic arch. B begins below the brachiocephalic. And then with that, then we need to look at the management for it. So what do you guys know about the management for it? Do they always need surgery? Do both types need surgery? Is there any kind of leeway with that? Perfect, you guys should be running this. So yeah, we'll come on to that, Shannon, but definitely. So you need to give labetalol to these people. Actually, we'll start with that. So here we are. As with all emergencies, you need to do an A to E assessment and stabilize the patient because they're going to be really acutely unwell. And be careful with their blood pressure because it could go two ways. They could have hypertension because of their body trying to make their cardiac output sustainable, or they could have hypotension because of blood loss and a host of other reasons. So generally, they say permissive hypotension is better in this situation. So you're going to aim for a blood pressure of around 120. So you're reducing those shearing forces and you're also kind of taking the pressure off their heart. And like you said, Shannon, you want to kind of lower their blood pressure aggressively enough to manage that and to get it down from 190 to 120, but also do it in a way that is not going to kind of cause rebound effects. So like a rebound tachycardia, for example. So you're going to give them beta blockers. IV labetalol is usually first line. You're going to monitor them and you really want to get their heart rate down to 65 and their BP at less than 120. Then, like Jack said, and even, I think everyone else is probably thinking it's also, Stanford A, you need surgery. And part of that reason is because if we go back to the picture, the aortic valve is within that. So when you kind of tear the aortic arch or the ascending aorta near the point of the valve, you basically reduce the suspension and the valve will swing down and become incompetent and you'll suffer with aortic regurg. So you need to kind of intervene quite quickly to fix that valve and also to try and deal with the tear because the position is more likely to cause severe symptoms. Whereas B, it could heal itself. If you take the pressure off, there's a chance that it could kind of start to repair itself. So you could manage it just with blood pressure control. However, if there's complications, then you would need to surgically intervene again, and that's an open surgical repair. I have no idea why there's a pericarditis picture there. I've just seen that. Ignore her. She's not meant to be there. Okay, so we've talked about that. And I know it's on this slide, but does anyone know the kind of investigation? What's the like main investigative imaging that you would need for aortic dissection? Yeah, CT angio. So CT angio with contrast, and that will basically show a little flap. And that will show you like there's the two lumens, almost like the true lumen of the aorta, and then the false lumen that's been made. And it's really important that you work out which is which so that you don't stent or that you don't kind of fix the false lumen and then kill them off. Also really important because a real common differential of this is ACS. And if you think of the management of ACS, it's thrombolysis. So that's the worst thing that could possibly happen to this patient. So you need to be really, really careful and make sure that when you do that CTA, that you've ruled out your MI picture, that you've ruled out the PE, you've ruled out your pneumonias, you've ruled out all those other things that could be weird and wonderful. Somebody said esophageal candidiasis once in my CCT, and I was like, wow, we're on a different plane here. But oh well. So, is everyone clear with that? Does anyone want to go over that bit again or anything Okay, cool. So heart failure. Again, what is it? I know you guys have probably seen it loads on placement, probably more than I have. So heart failure is when your body and your cardiac output cannot meet the demands of your body. So that's reduced cardiac output, which has tissue hyperperfusion, increased pulmonary pressure, and then you get this buildup in this edema. And you've got two types. Does anyone know what HFpEF and HFrEF are? Perfect. Yeah, reduced and preserved ejection fraction. Well done, guys. So basically, we use ejection fraction, which is the percentage of blood that's ejected from the ventricle and contraction, to assess how severe their heart failure is and what type they have. Because there's two types. So HFrEF, the reduced ejection fraction, they have an ejection fraction of less than 40%. So what happens is they've had a systolic dysfunction and they're not able to, how do I explain this? Then they're not able to kind of contract well enough to actually push out the blood. Whereas, and that's why they have a reduced fraction. Whereas in HFpEF, it's diastolic dysfunction. So they can't actually fill in the first place. So the blood's coming in, but not enough because the muscle is really stiff. And then when they contract, which works as normal, it looks like they're ejecting an appropriate volume of stuff in terms of percentage, but in terms of actual needs and meeting the body's demands, they're not going to meet it. So again, HFrEF, systolic, HFpEF, diastolic. Is that clear? And the way that we establish ejection fraction is with an echo, which is not something I realised and would have made things a lot simpler. So echo is how you find the ejection fraction. So therefore, with that being said, give me some investigations that you think you might need to do to assess heart failure. Chest x-ray, what kind of things would you see on a chest x-ray? Yeah, echo, BMP, ABCD. This is really good. What stuff would you see on a chest x-ray? Why would you be doing it? Yeah, perfect. Well done, guys. So I don't know if you can see, so we're saying some really great things here, like curly B lines, cardiomegaly, alveolar edema. Like, this is really great. So I like that shortened version, cardiomeg. That's what the cool kids call it. Yeah, so obviously with that, so starting again with that E boxes thing, assessment, E, exam, A to E assessment, stabilize that patient. B is bloods. So what bloods could I do for that person? A full blood count, and you want to look for anemia. I want to rule out kind of an infective picture. And then BMP, so that's probably the major way to diagnose heart failure in terms of blood tests. It's a really sensitive marker as well, much better than like ANP. Troponin, because I want to rule out a cardiac picture. It could be that they've had an acute MI and that's led to this heart failure. TFTs as well, because that could cause the edema picture. And then chest x-ray, ECG, and echo, and that's the special test, and that would help us work out the ejection fraction. Really good, guys. Well done. That was so good. So in terms of a buzzword in a question, we've said about what kind of things, and just tell me them because I know you guys know them, about what kind of symptoms and signs would we be expecting? Hold on, I think I just missed something as well. So how do TFTs cause edema? No, so it's not the TFTs. It's there's the very rare times where like thyroid storms can cause it, and so can I think there's a very distinct. In fact, I think I wrote it down here because I knew I would not remember it. You'd hope. I'll message you because I definitely wrote it down. But I think it's essentially if in a thyroid storm you can get kind of a generalized edema picture, and in hypothyroidism as well. But I'll write that down and I'll message you about it. Cool, put it in the document. So, no worries. Yeah, but like I said, so P&D, orthopnea, edema, these are all really great. Make sure you can as well explain why all of them happen. Yeah, cough productive of pink frothy sputum, there we go. So again, make sure you can explain all of them. So orthopnea, why do you get that? It's removing gravity, so the pressure and there's increased venous return on the right hand side, which causes pulmonary congestion, which makes them breathless. being able to explain that will be really helpful in understanding it and then remembering it. They'll also have those risk factors too. We won't go over right versus left heart failure because it sounds like you guys have got it down. But if you just think about the anatomy and the fact that the right-sided heart failure tends to be more bodily edema symptoms, whereas the left heart failure tends to be kind of the internal congestion symptoms, if that makes sense. So how are we going to assess them? We've talked about that. We've talked a little bit about what buzzwords we'd expect to come up. We could talk about an OSCE link, but I think hopefully it's kind of clear. I've had a cardiology history as heart failure in 3rd year, ATE assessment again, cardiology exam. Those are probably the main ways it could come up. So we've talked about how we diagnose it as well. So investigations are always great for diagnosis, but history is usually really great for management. And without it, we can't really manage the patient. So in particular, there's one thing we want to know from the history that would help us work out our management plan for this person. Does anyone know what that might be? So we're thinking kind of particularly an exercise tolerance. We're looking at their baseline, particularly with acute heart failure. Yeah, perfect. Yeah, so we're looking at their activity baseline and we're seeing about, how much intervention we can offer for them and kind of how their prognosis is going to kind of play out for them. So you have, I'm not going to go through it. You can learn it. It's one of those things to just sit and go over with a cup of tea. But essentially, the higher the number, the more severe your symptoms are. And it's kind of important to be detailed with it. It's not just enough to say, can you do what you want to do? It's, if you get dressed, are you breathless? If you go to the toilet, are you breathless? Can you walk downstairs without getting breathless? How far could you walk a month ago? How far can you walk now? And like really nailing it down to that. Cool. And again, this is the management plan. We won't go over it because I think it's something just to kind of go over in your own time. But I guess things to point out is in an acute picture, you're looking at using loop diuretics like furosemide to get rid of that fluid and diurese them. But then generally, kind of day-to-day heart failure, you're looking at giving them a mineralocortic, you know what I'm trying to say. You're going to give them spironolactone. So I guess that's something that I would emphasize and maybe isn't always that clear. So loop diuretic acutely and a high dose in IV and then oral spironolactone otherwise. Cool. Won't go over interventions that much because they very rarely happen. There's a spelling mistake there, which I'll correct when I send it out. So this is an intra-aortic balloon pump, really invasive. You basically put a balloon into the aorta and it inflates that diastole and it then deflates in systole. Think about the kind of significance of the kind of surgery that you'd need to have that done. Think about how invasive it is. Often people with acute heart failure are a bit older, they might be more frail, and they might not survive this surgery or this intervention. Similarly with the left ventricular assist device, you're essentially putting a pump into the heart and connecting it, and you connect it to the external world using a hole in the abdomen. They then carry a bag around with them, and it's great because they can be mobile, but it's quite an invasive procedure. And I think it would kind of stress me out having my heart in my backpack, but that's just me. Okay, what are we on now? Cardiac tamponade, right? This is the second to last thing now, so we're nearly done. You guys are doing really well. I think this is something that's not always taught that well, but does someone want to just give me like a 1-sentence summary of what it is, what cardiac tamponade is? Yeah, perfect. Perfect. Well done, guys. So cardiac tamponade is, these are all, you're all saying, yeah, completely right things. So in the spectrum of pericardial effusion, which is fluid of some form, whether that's blood, whether it's pus, whether that's kind of, we're the main two to be honest, but they're tissue fluid, I guess, maybe, but some form of fluid in the pericardial cavity, and that's the effusion. And cardiac tamponade occurs when this kind of builds up or accumulates to the point that it actually compresses the heart muscle and restricts its movement. So you get 3 classical symptoms in it, and that's Beck's triad, and it's the 3 Ds. So does someone want to hit me with the D? Come on. It's just someone post up there. Does someone, if anyone knows them? Yeah. There we go. Yeah. Smashing it. There we go. So descended JVP, muffled or distant heart sounds, and then decreased blood pressure or hypotension. And those things, they're not going to necessarily explicitly state them, but they will say, they might ask you, this person has hypotension, this person has a bit of chest pain, and you can't hear their heart sounds. What else would you like to look for on examination? So you say JVP, and that's their way of assessing that what Beck's triad is. And again, this is like a progressive picture. So this is decreased exercise tolerance, progressive shortness of breath, progressive pain over a few days, maximum a week or so. And it tends to come linked to malignancy. So the most common cause of cardiac tamponade is malignancy, particularly breast and lung. And it's not necessarily the actual malignancy itself, it's often more the actual treatment. So if you think about where your breasts and your lungs are, if you have radiotherapy, it can be quite an inflammatory process, and you can cause pericardial inflammation, which can then lead to fluid accumulation. So that's one of the most common causes. But also it's linked to other things as well. So blunt trauma, often when people have a car crash and they have an airbag, great, saves their life, but that blunt trauma to the front of their chest can cause a tamponade too. So in this case here, this person's got no medical history, but if anything, that would make me worried, because I'm like, why does he have a tamponade? Does he have a malignancy that they've not found? And I would link that to the VTE kind of pathway in the CBL that some of you will probably have had by now. When someone comes in with a VTE that's unexplained, one of the things you need to think is this because of cancer, and should I investigate this? And I thought that CBL was the one I had anyway, was quite good at kind of explaining that. But if not, let me know. I'm happy to run through it with you. They also have a couple other things. They've got this man here has ankle edema. He's got his raised JVP. He's got his distant heart sounds. He's got a blood pressure of 120, which I think is slightly, I'm not sure I'm going to call that hypertension, but fine. And he has pulsus paradoxus. So this is I always get this confused with Kussmaul, but essentially pulsus paradoxus, you have a fall in your blood pressure as you inspire. And it should be more than 10 millimeters of mercury. That's different to Kussmaul sign, which you'll find in pericarditis. And that is a sign where you breathe in and your JVP increases. And again, I think part of why they get confused is because pericarditis can cause cardiac tamponade, and they both have the extended JVP, they both can have hypotension, they're probably the main things. So I can see why they get confused, but it's really important to remember that pulsus paradoxus is cardiac tamponade and pericarditis is Kussmaul sign. Is that clear? Any questions? So I've just put a little bit there about pulsus paradoxus as well, and the kind of conditions you get it in. So pericarditis, cardiac tamponade. Again, once more, it's an emergency. Stabilize and do an A to E assessment on this patient. That should be your initial management and investigation and everything else. E boxes. E, we've covered. B, what bloods would you want to do? Yeah, full blood count. You'll pretty much never be wrong to say full blood count. So full blood count, maybe ESR. So you're looking at the, again, remember we were saying about malignancy. So you might want to do a chest X-ray. Hypothyroidism can cause, yet again, I don't know why, I'll research. But so you might want to do their TFTs, baseline UNEs and LFTs, clotting, because you're probably going to have to intervene. It could cause bleeding. And then the main kind of investigations are your ECG and your echo. And there's 2 really distinct signs, which I love for cardiac tamponade, because it's one of the rare times where this sign definitely means this. So the 2 things. Has anyone heard of electrical alterans before? Well done, Stephen. So if you see here, this is the QRS complex, and it's of alternating kind of amplitude, so height. And that's essentially because the pericardium is filled with fluid and is swinging in its most simplest terms. That's why you get this altering amplitude, which is really interesting. And you also get, on echo, you'll see collapse of the left atrial ventricle. In particular, it will almost completely invert. And that's part of why these people are so acutely unwell, is because they're just not getting any output. So how are we going to manage that? Obviously, it's really severe. We're really worried about this person. Often we might need to act before we've even done that imaging. So what are we going to do? How are we going to try and manage this person? So can you see this picture here? This is, yeah, perfect. Well done, Chris. So this is pericardiocentesis. Centesis meaning basically like removal of or extraction, and then pericardium, so removal of something from the pericardium, and you're basically going to draw out some of the fluid, whatever it may be, with a large needle, and hopefully that should quite quickly resolve some of the symptoms. And again, if they're severely unwell, you might have to do that without any imaging, but you need to image them afterwards, because you can't just shove a big needle into someone's heart and hope for the best. Well, the pericardium. Cool. Last one. Well done, guys. Pericarditis. So pericarditis, what do you guys think that means? What's that? Oh, sorry, do you do it with ultrasound guidance? So that's completely dependent on how severely unwell they are. So hopefully you could get the ultrasound, but I don't know if I've been in A&E this year, and to get the ultrasound can take about 5-10 minutes. They're like faffing around. There's one ultrasound machine, and I think it's in Miners, but I would not bet on it with my life. So if they're really unwell and you don't think you're going to get the ultrasound in time, take the needle and you go under the xiphisternum, or at kind of like a 15-degree angle, and just by the left sternal edge and the xiphoid, and you just kind of like push it in and hope for the best. Not too far, very gently ease it in, remove some of the fluid. It should come back quite quickly, and again you should have like quite a quick resolution of symptoms. Ideally though, you would do it with ultrasound, but it's one of those of, if the ultrasound's not going to come in time, they're going to die anyway, so might as well do something, as terrible as that sounds. Yeah, does that make sense? Okay, pericarditis. So this is, no worries, so inflammation of the pericardium, and they get this really, really classic picture. So it's this like pleuritic chest pain. It's quite acute, so days, over the past week or couple of days or whatever, and it's worse when it's just kind of worse when they breathe in, and better when they lean forward. And then really interestingly, they get this kind of radiation to the trapezius ridge, which is this ridge here. And so it's kind of like shoulder pain, and then it can go down the arm as well. So acute pleuritic chest pain, better when they lean forward, and they might have some shoulder or arm pain. Then again, really classically, they have a prodrome of fever, myalgia, and malaise. And that's because a lot of pericarditis can be linked to virus. Wow, I've been in lockdown too long. Or there might be a link to some kind of immunocompromise. So that's HIV, that's your SLE, your Marfan's, your SLE, your cancers. And then the very last version that you could get is post-MI. You get a very specific form of pericarditis called Dressler syndrome. Usually like a couple weeks after the MI, they present with this pain, and you might be like, what is going on? And then they just happen to mention that they've had an MI 2 weeks ago. Cool. Does that make sense? So what investigations do you think we'd want to do for a pericarditis patient? Yep, ECG, definitely. And they get really suggestive changes with that. Even before that, what kind of stuff would you want to do? So again, I know I keep pounding this. Yeah, A to E, well done. Exam, yeah, what's the in E-boxes? Transthoracic echo, great, very, very true. You want to look for a tamponade, but even before that, go back. So exam, bloods, yes, so bloods. So we want to rule out everything else. We want to rule out an MI. We want to check, so do like cardiac markers, full blood count, check their white cell count, because it could be there could be some like lymphocytosis going on. Liv, you're completely right. You want to, in that exam, listen to the heart. You're looking for a pericardial friction rub, which sounds kind of, as it suggests, like a friction kind of rub noise. I'll see if I can try and find like a link to the noise and put it in the document. Do you do viral serology? So it kind of depends on the patient and their history. So thinking about travel history, thinking about sexual partners, thinking about immune status, it probably wouldn't be the first thing on your list. If they've become admitted to hospital, you would consider it, because some patients, they come to hospital with pericarditis and they just get admitted straight away. And that's because they have cancer, or they have that immune compromise. They have a white cell count that's quite high, which is quite a bad marker for prognosis. So those are the people you would do a viral serology on. Does that make sense? And then, as people said before, definitely do an ECG. And you get this really characteristic saddle-shaped ST elevation. So it's not the same as the STEMI ST elevation, where the isoelectric line is quite raised off the isoelectric line. This is only a little bit raised. And also they can see here, they've also got some PR depression as well. There's not really much more to say about it than that. It's literally just ST saddle-shaped elevation and PR depression. Cool. And then we won't go through these. This was just me being like, be aware, hypertension is an emergency in and of itself and can cause end-stage damage. And also be aware of cardiogenic shock. Very fair game for them to ask you about the signs of shock. Very fair game. So I use the mnemonic I shock for it. But if you can just whittle off a few, respirate, sinus tachycardia, oliguria, hypertension, whatever, then that's fine. And being aware of the different kinds of shock. So cardiogenic shock is specific to kind of cardiac dysfunction. You have a cardiac event, usually an MI, and then you're not able to meet the cardiac output levels. But obviously, and that's very different to hypovolemic shock. So therefore, the way you treat it, you need to be careful. If you just whack this person with a load of fluids, you run the risk of overwhelming them even more. Okay, I have a little Kahoot quiz. Do people want to do it? Please say no if you don't want to. I really don't mind. Oh, okay, yes. Good. Okay, it's not very good because I'm not very good at technology. I'm going to try and stop sharing for a second and swap over, and we'll see if we can make this work. Okay, how do I do this? Please help. Okay, can you all see this? So what does this ECG show? Hopefully it's clear. I'll put my screen on. Oh, music. This is very intense. Maybe I'll see if I can change the music. Cool. So, well done, guys. That seems to be majority saying atrial fibrillation. Don't worry if you didn't get it, because ECGs are hard enough to interpret when they're in front of you, let alone on my computer screen, which you're viewing. If I show you the picture, so if we look at it here, these are the T waves here, but there's not really any distinct P wave following that. Also, it seems quite fast. I know there probably wasn't time to do a full formal assessment, so I kind of snaked you guys there a bit. But does that make sense? So there's these T waves and then there's no P wave, and it seems quite fast. So even though there's no obvious like fibrillation or shaking, the absence of P waves and an irregular pattern, which I think there is, should suggest atrial fibrillation to you. There we go. But don't worry, like I said. Well done. Oh, Shannon, you should have claimed to be Shannon because they're doing really well. Okay, let's keep going. It's too late now. So what does this ECG show? I love this music, wow. Yeah, so a bit more difficult this time around, and I agree completely again. So the main two differentials here would be acute pericarditis and STEMI. So it's really good that you guys all went for one of those two. Don't worry too much about it, like I said. I guess the thing that would differentiate between these two, and this is quite tight, is, can you see here, the kind of upsloping of the QRS complex? That's much more typical of a pericarditis picture, that saddling of the ST. I know this one potentially isn't as saddled, but it's only really in one lead, and STEMIs tend to be 2 chest leads minimum that need to be elevated. The ST segment needs elevation. Does that make sense? I appreciate that it's a kind of a complicated one, and I think they'd be very mean to give you that without some kind of clinical history as well. So don't worry too much about that one. Okay, next one. Oh no, sorry. So which of these are not part of the acute management of ACS? Yeah, well done. That was really good. So beta blocker is not part of the acute management. It is important to the management, so you'd be completely fair game to reference it in your kind of general management plan. But in the kind of initial stages of ACS, you're worrying about kind of providing oxygen, getting as much oxygen to the tissue as possible, vasodilating them, and treating the pain. Beta blockers will kind of reduce the strain on the heart long term, but it also takes a bit of time to work. So giving a beta blocker acutely isn't necessarily going to fix things unless you gave it like a high dose IV. Does that make sense to everybody? Okay, next one. True or false? Oh, hold on a second. So patients with AF who develop hemodynamic instability should be defibrillated. True or false? Sorry, I'm not reading these quick enough for you guys. I know this is live or death, so I'll do it quicker. Yeah, well done. So this was a bit of a difficult question again. I was being vague, well not vague, but defibrillated versus cardioverted. So remember we said before, cardioversion is synchronized, and we use it when someone has a pulse, and we use it to kind of start the regular normal pattern of the rhythm. Whereas defibrillation, we don't synchronize it. They have a risk of turning into VF. So we use it for times where they're already either in VF or in pulseless VT. So it's not really, if they go into VF, they're probably not much worse off than they already were. And also, it's a time when we can't synchronize the pulse, so either there is no pulse or it's too fast. Does that make sense? But we do need to do something, because AF and hemodynamic instability is an emergency, and they have significant mortality, so you really need to kind of do something to try and shock them back in. Any questions with that? Cool. Next one. What are we up to? What's happening? Oh, well done, Zoe. Doing very well here. So is everyone else, so, but well done, Zoe. So, PEA is a shockable rhythm, true or false? How was that? Yeah, well done. Smashed it, guys. Yeah, nothing to say about that. We'll just keep moving on. 6 of 10, so we're getting there. So, Stanford A aortic dissections require surgical intervention. What are we thinking? Yeah, well done, guys. So remember, Stanford A are the ones that occur in the ascending aorta and the aortic arch, so it's all those A's, and they tend to have more complications with it because of the position and the nature of it, so you need to intervene surgically. And also, if you think about the aortic valve, when you dissect at those points, it tends to become incompetent and lose its support, so you need to fix that. Okay, well done. Let's keep going. We're going to keep pushing through. Okay. Number 7. Which of the following conditions are linked to aortic dissection? Or grammar from the inside. So, Marfan syndrome. Well done, guys. All in there. Smashed it. Oh, someone's making a comeback. Come on now. Next question. Which of these signs are not in Beck's triad? oh, sorry, I don't know how to speed this up. Okay, it's too late now. So, yeah, well done, guys. So, tachycardia, I thought this was quite a difficult question, but clearly I haven't been listening to my own PowerPoint. So, tachycardia is not a sign of Beck's triad. It's the 3 Ds, your distant heart sounds, your decreased blood pressure, and your distended neck veins. Tachycardia is often a sign in cardiac tamponade, though. It's that kind of compensatory mechanism. Okay, what are we doing? And wow, people are on answer streak 4. This is very good. I'm proud of you all. Right, 9 of 10, nearly there. What is this abnormality known as? Ooh. Well done, guys. Electrical alterans. So that's that kind of alternating amplitude of the QRS complex that we see in a pericardial effusion. That's kind of, well, a cardiac tamponade, and that's because, again, it's compressing it and swinging. So, okay, scores on the doors. Oh no, one more question, I think. Yeah, go on, Amelia. Last one. Which blood test would be most useful for diagnosing heart failure? Perfect. Well done. Very proud of you all. Yeah, BMP is used for heart failure, and it's usually, when it's raised in heart failure, it's really raised, so we're thinking thousands, not necessarily like hundreds. Cool. Oh, I spelled quiz wrong. Ooh, never mind. Well done. Well done, Jay. Well done, James. The J theme today. But come on, in the end, well done, guys. That was really good. You all did so well. I was really impressed with that. 10 out of 10. Look at this. Yeah, I'll stop sharing for a second whilst you all celebrate your amazing scores. Ooh, and the music keeps playing. Let's get rid of her. So that's pretty much the end now. Did anyone have any questions or anything that they wanted to say? Or anything that they want making clearer, or if there's any topics in future that you want me or somebody else to cover? No worries. Thank you very much for coming and staying. What I'll do is I'm going to post this survey. Thanks, Joe. There we go. I'm going to post this survey. If you could fill in the survey for me, that would be so helpful. And I really enjoy teaching, but this is something as well that, as part of my course this year, I'm trying to show that I've been working on and developing. So I'd really appreciate that. And in return, yeah, I will send you this document. So it's basically just goes through a lot of what we've covered today and has a bit more detail for ECG interpretation, STEMI management, and I'll add in those extra bits that we mentioned before as well. Is there anything else that you want me to cover in that document? No worries, guys. Thank you very much. That's very kind of you. I appreciate the thanks. Yeah, make sure you look after yourselves. It's strange out there. Okay, yeah, I sent in the survey. Let me know, send me a message if you need anything, and I will end the call. Okay, bye guys. Wait, everyone got it? Okay, bye guys.